The First Amendment is Amendment 23962. It is included in the base text. Part of it is included in the base text of the Republican substitute. The First Amendment would make Medicaid the payer of last resort. By statute, Medicaid is the payer of last resort, which means anyone else, any third party, must pay first. Within the Deficit Reduction Act, we provided funds for states to set up electronic verification for third-party responsibility. The reports from the field have not been encouraging, with third parties not wanting to pay their share and states lagging on passing needed legislation to establish these programs. In 1996, Congress passed HIPAA, which in sections 1171 and 1176 provided a mandate that health plans reply to standardized electronic commerce messages. In 2003, audits of 6 Medicaid authorities uncovered problems with 20% to 36% of claims sampled. These audits exposed the ineffectiveness of the standard pay and chase third-party liability program. In 2005, California and Washington each audited their claims and found that between 16% and 19% of those claims were fraudulent or abusive, roughly bearing out prior surveys. The Government Accountability Office has backed up these findings, assuming a national error rate of 20%. The waste of taxpayer assets on unlawful Medicaid claims exceeds $45 billion per year. The amendment requires that all states show compliance with the statute that Medicaid is the payer of last resort. States that are certified to be in compliance get a $2 million bonus. States that become compliant get a $1 million bonus. States that are not in compliance after 1 year would see a 1% reduction in the FMAP they receive until they become compliant. This is simply a good government amendment and should be accepted. The amendment will ensure that all states are taking needed steps to enforce current law and keep their programs up to date in the realm of the payer of last resort. No third party should shirk their responsibility. The third parties we're referring to here are the private insurance companies. They should not shirk their responsibility, and with the expansion in the Medicaid provided under the bill, a strong third-party electronic verification system will become even more important. I would stress that in the GAO report that came out in 2006, the rate of non-compliance of this was estimated between a low of 11% for California, a high of 25% for the state of Iowa, but across the board, it is a significant amount of money. At the end of the day, no one wants a medical provider to bill the wrong payer, and no one wants the wrong payer to pay. We all want to know that the payer who is required to be the primary payer, in fact, pays the bill. Again, that is part of the underlying Republican substitute, and I offer that as an amendment to the base bill 3962. Second amendment gets to one of the issues that Dr. Fox brought up earlier in the discussion with the committee chairman. This would rate insurance policies because would allow insurance policies to rate for tobacco use. The current bill under discussion has very strict rating rules, and generally I'm sympathetic to limiting insurers' ability to use loose rating standards to their advantage and for adverse selection. However, I believe not allowing some variation for smokers is an oversight. This amendment is not without precedent. Private companies are now charging employees more to cover health care costs if the employee smokes because of the increased cost of the company to insure or cover them. In fact, a growing number of private and public employers are requiring employees who use tobacco to pay higher premiums and actually using that as an incentive, a negative incentive, to motivate some of them to stop smoking and lower health care costs for the company and, of course, result in better health for the employee after they stop smoking. While the amounts range from about $20 to $50 a month, it is an important point. Smoking has, despite the fact that it's regulated by the Food and Drug Administration, smoking has absolutely no health benefit and should absolutely be discouraged. With smokers costing companies about 25% more than non-smokers in the area of health care, it just makes good business sense. This amendment would allow rating as long as it should not vary by more than 1.5 to 1. The Center for Disease Control and Prevention estimates $92 billion in lost wages annually in the United States from smokers who die prematurely. In addition, the economic cost of smoking includes over $75 billion per year in direct health costs. Insurance companies spend more on medical expenses for smokers than on non-smokers. Overall, for every package of cigarettes smoked, that smoker costs the nation over $7 in medical care and lost productivity. Each year, a staggering 440,000 people die from tobacco use. One in every five deaths is related to cigarette smoking. Allowing a slight variation in rating for smoking makes economic sense, and it makes medical sense. The Third Amendment, which is included in the base included in the Republican substitute also, but I'm offering it as an amendment to the 3962, is regarding medical liability. Of course, we've all heard that many doctors are forced to practice defensive medicine and face the constant threat of lawsuits and unsustainable medical liability insurance rates, which result in millions of dollars in unnecessary tests and procedures. I should know the profession of obstetrics and gynecology is one of the strongest, where defensive medicine has to be one of your strongest subjects because you're constantly under threat. Seasoned medical professionals are retiring early because staying in practice is no longer financially feasible, further contributing to our nation's doctor shortage. There's a growing crisis that is pushing affordable health care beyond the grasp of millions of Americans. The amendment would require a national across-the-board change in the medical justice system that would lower costs and improve care by lessening the threat from unmerited lawsuits. Cap non-economic damages at $250,000, an aggregate cap, though, that totals $750,000 in sum. $250,000 cap for the doctor, $250,000 cap for the hospital, a $250,000 cap for a second hospital or a nursing home if one is involved. Caps on wrongful deaths would be wrongful death awards would be capped at $1.4 million. Expert opinions relating to physicians may only be provided by physicians who are actively in practice. Payment of future damages are on a periodic or accrual basis. Limitations on liability for good Samaritans providing emergency services. This is not a theory. This is a fact. It has worked in Texas since 2003. Lawsuit reform in Texas has created a magnet for doctors and provided the funding mechanism to improve access to care and enhance patient safety through significant savings. In 2003, Texas passed sweeping medical liability reform, and the results have been better than expected. According to the Texas Medical Association, charity care rendered by Texas hospitals rose 24% in the 3 years following the reforms. Texas has licensed almost 15,000 new physicians in the 5 years since the reform passed, a 36% increase from pre-reform. But this is what is very important. 33 rural counties have seen a net gain in emergency room physicians, including 26 counties that previously had none. After years of decline, the ranks of medical specialists are growing in Texas. In my field of obstetrics, Texas saw a net loss of 14 obstetricians in the 2 years preceding reform. Since then, the state has experienced a net gain of 192 obstetricians. 26 rural counties have added an OB doctor, including 10 counties that previously had none. A vote against this amendment will reaffirm that the commitment is not to our nation's doctors, but to the nation's trial attorneys. A vote for this amendment will tell America's doctors that we are committed to putting in place reforms that will allow them to do their job. Interestingly, we were talking about the American Medical Association just a few moments ago. This is one of the top priorities for the American Medical Association, and one of the reasons, quite frankly, that they endorsed the underlying bill. Not doing this will actually negate any of the benefit to America's doctors that might occur within the bill. One of the other things that is so important to the nation's physicians is my next amendment.
How many amendments do you have, Mr. Burgess?
8.
Okay.
Next amendment would require Medicaid payments to be 75% of what would be standard in a government insurance or standard in one of the state-based programs. For too many, Medicaid is an empty promise. It puts care beyond the reach of the poorest citizens. Those with Medicaid find themselves unable to access services because Medicaid pays less for comparable service than private insurers. It pays even less than Medicare. Patients then soon realize that coverage does not equal access. Medicaid payment shortfalls lead providers to cost shift or reduce charity care. At worst, providers simply refuse to accept Medicaid patients or limit the number that they treat. We can reform healthcare in this nation, but the first step, the very first step, should be to fix that part of the medical care in this country that is already known to be broken. Time after time, providers cite lower reimbursement and paperwork concerns as the two most important reasons for limiting their participation in Medicaid and S-CHIP. While doing business with the government will always include excessive paperwork, we can help fix the issue of reimbursement. The amendment states that payment for all services under Medicaid must be paid at least 75% of the rate of a state employee plan or the FEHBP plan most chosen by families. In the case of vision and dental, 75% of the rate of the state employee supplemental plan or the federal employee health benefit plan supplemental, most often chosen by families. Nearly 1/3 of pediatricians report they would accept more Medicaid patients if reimbursements were increased. The Michigan Medical Society found that Medicaid pays less than half of what private insurance pays for the exact same service. Instead of tying rates to Medicare, which has reimbursements of its own, let's try linking to private rates. I don't think there's any question what the nation's doctors would prefer. Another point that needs to be considered is the Medicaid provider networks. As a practicing physician for over 25 years, I'm really one of only a few of our colleagues who's actually treated patients under the Medicaid system. It's startling when I hear that some believe that expanding Medicaid in its current form is part of the solution in covering our nation's uninsured. The bill seems to recognize some of the shortfalls in the program by linking some payments to Medicare, but Medicare is problematic itself. But then you add 16 million more people to the program, and we really see that we need fundamental Medicaid reform. And clearly the question is, if we don't do it now, when will we do it? Well, what if members of Congress were required to get off the sidelines and walk the talk in health care? I'm a Republican. It's not often that you'll hear me advocate for a new mandatory population, but what if we created a mandatory population of all 535 members of Congress so that they would know what it was like to be insured under the Medicaid system? We can reform health care in this nation, but the first step should be to fix what's broken. Perhaps we could be more creative and successful in making meaningful reforms to our country's health care system that would be a step forward for all Americans. This amendment would allow members of Congress to sign up for Medicaid, just like any other of their low-income constituents, to see what a Medicaid patient has to deal with. Members of Congress would now be a mandatory population in statute, and all asset tests would be waived of necessity. The federal government would assume 100% of the cost of the coverage. We would not push the FMAP onto the states. The next amendment deals with ensuring a network adequacy before Medicaid expansion. It gets to some of the things that Mr. Cardozo was talking about with his pediatric network for neonatologists. In Medicaid, like other federal programs, we clearly see the need for reform. Research has shown that Medicaid enrollees face significant challenges in finding a health care provider that will accept Medicaid coverage. Medicaid patients soon realize that the promise of Medicaid does not always provide them access. A 2006 report by the Center Studying Health System Change found that nearly half of all doctors polled said they had stopped accepting or limited the number of new Medicaid patients. In contrast, over 95% of the doctors polled in the same survey said they were accepting new patients that were covered through private health plans. This amendment would require each state to certify to the Secretary of Health and Human Services that they have enough primary care providers to see patients and children currently under their program. Each certification shall be accompanied by a survey demonstrating network adequacy conducted by the American Academy of Pediatrics, the State Medical Society, or another qualified provider-based organization. Once such certification is received and accepted by the Secretary, the Medicaid expansion provided for under the bill would occur in the following year. One of the things that the next amendment deals with the CBO scoring. One of the things that concerns us with this bill is, are we accurate in our projections on what this bill will cost? We're presented today with a CBO score that says this bill will cost approximately $1 trillion and cover 96% of the people. And we say the bill will be fully paid for. In fact, the president's own words, add not one dime to the deficit. I'm oftentimes frustrated with the Congressional Budget Office. I know they are individuals with great integrity, and I believe their estimates are based on sound math and science. However, what happens in year 11 of this bill? How much of the pay-fors will be counted as part of the baseline after 10 years? The taxes you raise on Americans under the bill will continue to generate money into the future, but the bill is not paid for indefinitely. It becomes yet another unfunded liability in the next decade of its existence. For those who might plan on being here in 10 years, after tonight I'm not sure about myself, but here are a couple of problems that await us. In 2017, Medicare Hospital Trust Fund goes bankrupt. 2018, the Social Security Trust Fund will start paying out in benefits more than it's scheduled to take in. 2019, how much money will Congress have to cut or raise in taxes to keep this bill going? I don't know the answer, you don't know the answer, but we do owe it to the American people to try to keep tabs on this process as it goes forward. All this amendment does is create a yearly report card for our efforts under the bill. This will allow each generation to know how well the bill is succeeding or failing on delivering the president's promise of universal coverage that will not add one dime to the deficit. Mr. Chairman, I don't want you to be disappointed. This is the last amendment that I have.
You have a lot of stamina, Doc, but I have more.
Now, we heard earlier, we talked about setting up the public plan, about the capital reserves that would be necessary for setting up the public plan. We acknowledge that it's going to be difficult to set up the public plan. In fact, without even naming an administrator for the Center for Medicare and Medicaid Services, it is going to be a Herculean task to get this public option up and running. This amendment would require that there be capital reserves required to carry sufficient liquid capital to prepare for or prevent a worst-case scenario. The regulatory reserves are expressed as ratios of premium income and claims experience. The buyer of insurance pays a premium against the promise that he or she will receive a payment if a specified random event occurs. If the insurer does not hold enough reserves to fulfill this promise, the consumer is being cheated. I will tell you from my experience in private practice, if you have somebody in the insurance business who is not sufficiently capitalized and does not have sufficient liquidity, and the economy hits a negative patch as we are in now, that insurance company may go away, leaving that patient to rely on a state pool that is in existence, and if many people tap that fund simultaneously, it becomes problematic as to whether or not that patient indeed has any coverage. A potential failure without adequate reserves undermines the confidence on which the market is based. It will be necessary for the public plan to have such a fund, and that fund should not be the United States Treasury. We're going to be risking more debt to enact this proposal. So the amendment would prohibit the United States Treasury from being used as a means for capital reserve funds. The amendment also clarifies that the public plan would need to seek investments or use premiums to create a capital reserve fund similar to that which is required of other health plans. Allowing the United States Treasury to be the ultimate backstop could encourage a plan to act recklessly, and we've already seen what happens in other industries when this is applied. While this bill prohibits bailouts of the public plan, using the Treasury as a promise of government backing is indirectly we're allowing such. The public plan can still use the full faith and credit of the United States Treasury to stabilize their risk. If it's good enough for business, it's good enough for insurers, even casinos. It should be good enough for the public plan. Shouldn't the public plan play by the same rules as everyone else? It's a simple amendment, and if the majority is committed to a public plan that competes with private insurers on a fair and level playing field, it certainly should be accepted without objection. Mr. Chairman, that concludes the amendments that I am submitting tonight, and again, I offer them for your consideration.
Thank you very much, Dr. Burgess.